Hello, everyone, and welcome to the second episode of our series on cardiovascular physiology. Today, we'll talk about the electrical activity of the heart. We'll take a look at the tissues of the heart, in particular the electrical conducting system. Then, we'll analyze the different action potentials of pacemaker cells and cardiomyocytes before delving deep into the EKG and electrical vectors, and we'll show you how normal and abnormal rhythms look like. Enjoy.
My name is Tiziano Russo.
My name is Francesco Sidoti.
And this is Above Average Med Students, where we make you confident in your medical knowledge. The heart is made up of three different types of tissue: muscle tissue, conducting tissue, and connective tissue. So for muscle tissue, there's not much to say. It composes about 90% of the total tissue of the heart. Last time we talked about layers of the heart, and I already explained you the difference between a skeletal muscle cell versus a cardiac muscle cell or cardiomyocyte. In case you didn't watch the episode or don't remember, you should know that cardiomyocytes have the peculiarity of having an intercalated disc between cells. An intercalated disc is a structure that connects adjacent cardiomyocytes, and it includes desmosomes and gap junctions. Desmosomes are structures that connect the cytoskeleton of two adjacent cells for structural support, whereas gap junctions are basically channels. They allow for the free flow of ions from one cell to another. Gap junctions in particular are super important because they allow the heart to contract as a syncytium. Better said, not the entire heart, but for example, we want the atria to contract simultaneously and the ventricles to contract simultaneously, and the presence of these gap junctions allow for a communication so fast that these cardiomyocytes are able to contract almost simultaneously. Then we have conducting tissue. Conducting tissue is made up of these cells that ensure an electrical communication between different regions of the heart, and whereas cardiomyocytes are the cells that generate the actual contraction and the movement to physically pump blood out, they only do so upon stimulation from these conducting cells, which are autorhythmic cells, which are able to generate their own action potential, thus determining how fast the heart will beat. Finally, we have connective tissue. Again, if you watch or listen to the previous episode, you might remember that there is a fibrous skeleton of the heart which supports the valves, as well as creating an isolation between the atria and the ventricles. Why is this isolation only present between atria and ventricles, and why is it so important? Because, as we briefly mentioned before, we want the atria to contract together and the ventricles to contract together, but we need the ventricles to contract after the atria. In other words, we need the atria to completely empty into the ventricles before the ventricles contract themselves and push blood out of the heart. So now let's focus on one specific type of tissue, the conducting tissue, and where it is located around the heart and how it works. First of all, you should know there are four main components of the electrical conduction system of the heart. We have the sinoatrial node, then the atrioventricular node, then the bundle of His, and finally the Purkinje fibers. So the sinoatrial node, which from now on we will just refer to as the SA node, is located in the right atrium. It is a specialized region in the right atrial wall, in particular in the endocardium, which is the pacemaker of the heart. What does this mean? It means that in physiological condition, when we're not around stress and when we don't have the activation of a sympathetic response, for example, the SA node is what sets the actual rhythm of the heart, meaning how many beats per minute the heart will have to do. From the SA node, we will have the stemming of two pathways, a horizontal one and a vertical one. The horizontal pathway is the interatrial pathway, and the vertical one is the internodal pathway. What is the difference? The difference is that the interatrial pathway will allow for very fast communication between the two atria, so that when the SA node fires stimulus, both atria will contract as a syncytium. The internodal pathway, instead, will run from the SA node to the AV node, which is the second portion of the electrical conduction system, which is found in proximity of the atrioventricular septum. Of note, the impulse will take about 30 milliseconds to travel from the SA node to the AV node. Once the impulse reaches the AV node, there will actually be a 100 millisecond delay. This is because, as we just said a couple minutes ago, we need the atria to fully contract and push all of the blood that they have into the ventricles, so that when the ventricles contract, we will get maximum efficiency. So these 100 milliseconds will contribute to helping the atria fully empty into the ventricles. From the AV node, we will have the origin of the bundle of His, which is a specialized tract that will start from the AV node and travel through the interventricular septum now. And in the interventricular septum, it will actually bifurcate to reach the apex of the heart. Remember, the apex is the most inferior portion of the heart, reaching the inferior tips, let's call them, of the ventricles. The impulse will take approximately 30 milliseconds to reach the apex of the heart. Here we will have the origin of the Purkinje fibers, which will make a turn and spread back upwards in the direction of the atria, passing through the epicardium this time, no longer through the endocardium, where most of the electrical conduction of the heart is located. So, just as a recap, we have the impulse generated by the pacemaker of the heart, the SA node. From the SA node, we will have the two pathways, interatrial and internodal. The internodal will take about 30 milliseconds to bring the impulse to the AV node, where we'll have a 100 millisecond delay. From the AV node, the impulse will travel through the bundle of His. From the bundle of His to the Purkinje fibers, the impulse will take about 30 milliseconds to arrive. From the Purkinje fibers, the impulse travels back up towards the atria. All in all, this process takes about 160 milliseconds. Now that we have seen in detail how the entire electrical conduction system of the heart works, let's focus on how a single cell of the system generates an impulse.
So as for any other excitable cell in our body, the cells of the electrical conducting system of the heart are able to generate action potentials. Their peculiarity, and this is why we call them autorhythmic, is that they can generate action potentials without the stimulation from a nerve. They just do it on their own. But how do they do it? First of all, we should mention that these cells have no resting membrane potential. You probably remember from class what is a resting membrane potential, but just to refresh your memories, it is the difference in voltage across the plasma membrane of a cell when the cell is in a non-excited state. And it is usually constant because it is given by the permeability to different ions and their concentrations inside and outside of the cell. The autorhythmic cells of the heart, instead, are continuously oscillating between periods of depolarization and of repolarization without ever stopping to a fixed membrane potential. And you would see this on a graph as a squiggly line, which is never horizontal. You could think of it as a sinusoidal line, for example, up and down, but never horizontal. So the first step for one of these cells to generate an action potential is to reach threshold, which in this case is set at minus 40 millivolts. Remember, threshold is the voltage that has to be reached from a cell in order for it to generate an action potential. So let's take an autorhythmic cell that has just finished the previous cycle of depolarization and is now repolarizing, approaching minus 60 millivolts, which is the lowest point that one of these cells will reach before starting to depolarize again. From the low point of about minus 60 millivolts, the cell has to reach threshold again in order to fire another action potential. And this rising voltage from around minus 60 to threshold is called the pacemaker potential. The pacemaker potential happens thanks to three electrical currents. We have an inward sodium current, a decreased outward potassium current, and an inward calcium current. Let's start from the inward sodium current. When the cell is approaching very negative voltages when repolarizing, we have the opening of funny sodium channels. Why are they called funny sodium channels? Well, because in contrast to other usual voltage-gated sodium channels present in other excitable cells, these channels open at very negative voltages, letting sodium flow inside the cell. The decreased outward potassium current is due to the closure of voltage-gated potassium channels at negative voltages. These are the channels that are in charge of the repolarization of the cell at the end of the previous cycle, and they will start closing as the cell approaches minus 60 millivolts to favor the depolarization of the cell to reach threshold, because less potassium ions will leave the cell, thus more positive charges will remain inside the cell, making it more positive. The increased inward calcium current is due to the opening of T-type calcium channels. Remember, T-type means they are transient calcium channels. They only open for a brief period of time. And these channels open as the funny sodium channels start closing, letting calcium flow inside the cell. So basically, the difference between the first part of the pacemaker potential and the second part of the pacemaker potential is that in the first part we have sodium flowing inside the cell and less potassium leaving the cell, while in the second part, while we still have less potassium flowing outside the cell, we have calcium flowing inside the cell instead of sodium. The flow of calcium ions through the T-type calcium channels is what will cause the cell to reach threshold and fire an action potential. You should know that there is also a redundant mechanism, independent from all of the currents we just talked about, that ensures that the cell can reach threshold. This is the calcium clock mechanism. How does it work? Well, we have the spontaneous release of calcium from the sarcoplasmic reticulum of the cell, and this calcium will travel to the plasma membrane where we have the sodium-calcium exchanger. This exchanger will transport one calcium outside the cell and let 3 sodiums inside the cell. Remember, a calcium ion has a +2 positive charge, a sodium ion has a +1 positive charge, but we are letting one calcium ion out for 3 sodiums in, so the net charge inside the cell is +1. So this favors depolarization of the cell. I know this was complicated, but bear with me, it was the hardest part of this whole process, and we'll have a recap at the end of it so you can better understand. But now the cell has reached threshold, and let's see what happens after threshold. After threshold is reached, we have the firing of the action potential, and it is made of 2 phases, a rising phase and a falling phase. In the rising phase, the cell will reach about +15 millivolts, and it is mediated by the opening of L-type calcium channels that will let calcium flow inside the cell. Remember, L-type means they are long-lasting calcium channels, meaning they open for quite a long time, in contrast to the T-type calcium channels. While the falling phase is mediated by the opening of voltage-gated potassium channels that let potassium flow outside the cell, and of course, by the closure of the L-type calcium channels. So let's recap the action potential of an electrical conducting cell. As the cell is repolarizing, it is about to reach -60, we have the opening of funny sodium channels and the closure of potassium channels, of voltage-gated potassium channels. This will make up the first part of the pacemaker potential. Then, funny sodium channels will close, while T-type calcium channels will open, producing the second part of the pacemaker potential, and the cell reaches threshold. After threshold, we have the opening of the L-type calcium channels that mediate the rising phase of the action potential, and then their closure and the opening of voltage-gated potassium channels that mediate the falling phase of the action potential, and the cell is now repolarized again. In order for the cell to restart the cycle, it has to reset, meaning it has to readjust the concentrations of ions inside it as they were before depolarization. The calcium that has entered the cell is taken up into the sarcoplasmic reticulum via Serca pumps. The sodium that has entered the cell is moved back outside the cell via sodium-potassium pumps, and the potassium that has flowed out of the cell is moved back in the cell still via sodium-potassium pumps. So we have seen the components of the electrical conducting system, and we have seen how a single cell can generate an action potential. Now let's take a practical look at the rhythm of the heart generated by the electrical conducting system and how it can be modulated and some potential abnormal rhythms.
So, earlier, when we discussed the components of the electrical conducting system of the heart, I told you that the SA node is the pacemaker of the heart, the natural pacemaker of the heart. I specified that because actually each individual component of the conducting system has its own rhythm, but the SA node is the one that prevails because its rhythm is the fastest. In fact, in the absence of any external modulation, the SA node would naturally fire at around 100 beats per minute. If we then proceed downwards to the other components of the system, the AV node fires at around 60 beats per minute, the bundle His and Purkinje fibers at around 40 beats per minute. But then, why is the SA node the natural pacemaker? Well, because if you think about it, like at time 0, as the cells present in each one of these components of the system start to depolarize and start their pacemaker potential to generate an impulse, the first one to get there is the SA node, the cells in the SA node, meaning that the SA node will fire and the impulse will arrive to the AV node before the AV node can by itself reach threshold. This means that the fastest engine at the beginning of the system, the SA node, will actually determine the heart rate. Now you might be wondering, if the SA node is the natural pacemaker of the heart, and I told you that it normally fires at 100 beats per minute, why isn't our resting heart rate 100? Well, that is because of the modulation of our autonomic nervous system. Our autonomic nervous system, which is a part of the nervous system that we cannot control and is divided in sympathetic and parasympathetic, actively, constantly modulates how fast our heart beats. It does so by controlling the permeability to certain ions in our heart. As Francesco said before, the main ions involved in heartbeat are sodium, calcium, and potassium. By increasing the permeability of our conducting cells in the heart to sodium and calcium, we will be able to reach a faster heart rate because the inflow of positive charges, therefore the speed of depolarization, will actually be faster than without stimulation. On the contrary, an increase in potassium permeability will slow down the heart rate because the potassium will be facilitated in leaving the cell. Therefore, repolarization will happen more quickly than depolarization. You should also know that the autonomic nervous system is able to modulate these permeabilities mostly through the action of cyclic AMP. The sympathetic component increases the amount of cyclic AMP that is produced, and the parasympathetic component decreases the amount of cyclic AMP produced. And most of the channels involved in the electrical conduction of the heart are actually sensitive to the cyclic AMP. Now, we are constantly under sympathetic and parasympathetic stimulation. However, in resting conditions, the parasympathetic component is the one that prevails. Therefore, our heart rate will actually be slower than the intrinsic rhythm of the SA node. There can be cases when the conduction between the different components of the system is impaired, or some of the components themselves are impaired. And this will lead to an array of conditions that we will investigate more in detail later on. For now, I just want to introduce the topic by talking to you about some possible abnormalities in rhythm caused by these problems in the conducting system. The first example is a failure of the SA node. Now, if the SA node, which is the fastest component of the conducting system, were to fail, the next fastest component in line, meaning the AV node, would take over. This means that from an intrinsic activity of 100 beats per minute, we would go down to an intrinsic activity of 60 beats per minute. If the AV node itself failed, then we will go down to the bundle of His, and the intrinsic activity would fall even further down to 40 beats per minute. However, this is not compatible with life. The second complication that I want to talk about is an impaired communication between the atria and the ventricles. This condition is known as heart block, and it will lead to the upper and lower chambers of the heart beating at different rates. In particular, the atria would keep beating around 70 beats per minute, whereas the ventricles, now under the control of the bundle of His and Purkinje fibers, would beat at a rate of 30 beats per minute. This impaired communication between atria and ventricles is very often given by a failure of the AV node. So we would have the first part and the last portion of the conducting system of the heart separated and with different rates. The third condition that I want to talk about is called premature ventricular contraction. As the name suggests, this means that the ventricles are beating faster than the atria, meaning that they are unable to fill completely with blood before pushing this blood out of the heart. This is due to what's called an ectopic focus, meaning that there is a part of the system, in this case the Purkinje fibers, which become overactivated and for some reason start firing faster than the SA node and the AV node. Possible causes for this condition to arise are a lack of sleep, as well as an excess consumption of substances such as caffeine, alcohol, and nicotine. Finally, the fourth abnormality that I want to talk about is fibrillation. Fibrillation is the result of a non-homogeneous contraction in different parts of the heart. We can have atrial fibrillation or ventricular fibrillation. In the case of atrial fibrillation, the atria will no longer act as a syncytium of cells, so that they all contract simultaneously and efficiently. But we will have different parts of the heart contracting at different times, to the point that sometimes even single individual fibers will contract without actually being able to push blood. And this is especially serious actually in the case of ventricular fibrillation, because the ventricles would not have enough strength and enough coordinated activity to push all of the blood back into systemic or pulmonary circulation. You should know that fibrillation can actually be fixed by electrical defibrillation. This is a process that will depolarize all of the heart cells simultaneously and act sort of as a reset button that allows the heart to start functioning again as a syncytium. Okay, now that you know everything there is to know about the electrical conducting system of the heart, I will give the word back to Francesco and he will explain to you how the action potentials of cardiomyocytes work.
So remember how I told you that conducting cells have no resting membrane potential? Well, cardiomyocytes actually do. And it is very low. It is minus 90 millivolts. And this is very peculiar because no other excitable cell has such a low resting membrane potential. In fact, cardiomyocytes present some very special channels, the so-called inward rectifying potassium channels, that we spent a lot of our time trying to understand because we were reading sources that were actually giving us contradicting information. But we drew the conclusion that these channels let potassium flow out of the cell at very, very negative voltages. In fact, as the cell is repolarizing, the ordinary potassium channels that are in charge of repolarization close, but these inward rectifying potassium channels open, making the resting membrane potential very, very low, around, as I said, minus 90 millivolts, which you might remember from your classes on cell physiology, that it is the same voltage of the equilibrium potential of potassium. In fact, cardiomyocytes are extremely, extremely permeable to potassium. Now, upon the arrival of an electrical stimulus to a cardiomyocyte, provided the stimulus is strong enough, the cardiomyocyte will fire its action potential. We can divide the action potential of the cardiomyocyte in 4 phases. A depolarization phase, a small repolarization phase, a plateau phase, and a fast repolarization phase. Let's start from the depolarization. In this phase, voltage-gated sodium channels, ordinary sodium channels, open and sodium starts flowing in the cell very, very fast, to the point where the membrane of the cell reaches around plus 20, plus 30 millivolts. Here is where we have the start of the small repolarization phase, where transient potassium channels open, and they mediate a fast but transient efflux of potassium from the cell, which results in a small repolarization. This repolarization is followed by the plateau phase. In this phase, we have the opening of slow L-type calcium channels, which mediate a slow inward flow of calcium, and the closure of transient potassium channels, keeping the membrane potential balanced throughout a short but relevant period of time. After the plateau, we have the fast repolarization phase, where we have the closure of the L-type calcium channels and the opening of ordinary voltage-gated potassium channels, okay, which mediate a fast efflux of potassium and thus a fast repolarization. At around resting potential, the potassium channels close, but we have the opening of the inward rectifying potassium channels, so the resting membrane potential can reach the minus 90 millivolts, okay? So, as a recap, we have the 4 phases. First phase is the fast depolarization phase, where we have the opening of voltage-gated sodium channels. You can imagine this phase as a big spike in the graph, very tall and big spike. Then we have a small repolarization phase, where we have the opening of transient potassium channels. And you can imagine this as a small dip from the peak of the depolarization, followed by the plateau phase, where we have the opening of slow L-type calcium channels and the closure of the transient potassium channels. You can imagine this as a more or less horizontal line coming after the dip, and then the fast repolarization phase, which is mediated by the closure of the L-type calcium channels and the opening of voltage-gated potassium channels, that you can imagine as a fast falling line towards resting membrane potential. Remember, of course, that at resting membrane potential, the inward rectifying potassium channels are open. Let's talk a bit more in detail about the plateau phase of cardiomyocytes. Why is it so important? Well, the plateau phase is crucial in order to prolong the refractory period of a cardiomyocyte. In case you don't remember, a refractory period is that time frame when a cell cannot be restimulated to produce another action potential. If we take a normal skeletal muscle cell, so not a cardiomyocyte, you'll see that its refractory period is very short. In fact, upon electrical stimulation, the skeletal muscle cell will generate an action potential and will form a certain number of cross bridges to contract. The refractory period, in this case, is so short that this cell, while still contracting, can receive another electrical impulse and generate another action potential and generate even more cross bridges, resulting in summation of contractions and a stronger contraction. Rapid summation of many contractions eventually results in tetanus, which is the maximal contraction, which corresponds to the maximal force which can be exerted by one of our muscles. Tetanus has to be avoided at all costs in our heart, because imagine if our heart kept contracting without ever relaxing. Of course, that would not be compatible with life. We avoid tetanus by prolonging the refractory period of cardiomyocytes in order for it to almost match the time a cardiomyocyte needs for contraction. In fact, the refractory period is about 250 milliseconds, while the contraction of a cardiomyocyte lasts about 300 milliseconds, so there is never significant summation. This means that by the time a cardiomyocyte is excitable again after the refractory period, most of the cross bridges that were formed at the beginning of contraction will not be there anymore, and the cell is already relaxing and basically ready for a new action potential to trigger contraction. So let's take a look at what is the mechanism of contraction of a cardiomyocyte. Well, you remember the L-type calcium channels that are open in the plateau phase of the action potential of the cardiomyocytes? Well, they are the main actors in the contraction mechanism. They are located in the membrane of the T-tubules of the cardiomyocytes, and they let a relatively small amount of calcium in the cytoplasm of the cell. This calcium has two main functional roles. The first, less significant role, is that it directly contributes to the formation of cross bridges, because you remember the contractile mechanism of cardiomyocytes is exactly the same of that of skeletal muscles, so it will bind troponin and start activating some cross bridges. The second, more important function is that it triggers the opening of RYR2 receptors, ryanodine receptors, that are located in the lateral sacs of the sarcoplasmic reticulum of the cardiomyocyte. These receptors are sensitive to local calcium concentrations, and they mediate the release of a much larger amount of calcium from the sarcoplasmic reticulum into the cytosol of the cell. And this large amount of calcium released from the sarcoplasmic reticulum is what will constitute the bulk of the calcium that activates the contractile machinery of the cell by binding to troponin and activating most of the cross bridges. I know that was a lot, but let's now put aside all of these action potentials, and we'll now focus on probably the most high-yield topic of all of the electrical activity of the heart, which is the EKG.
Alright, so we're going to try to be as methodical as possible in this explanation of the EKG. So first of all, let's start with a definition. An EKG, or electrocardiogram, is a recording of the electrical activity of the heart. This activity travels from the heart to the surrounding fluids and tissues and reaches the skin, where we place some electrodes that we use to measure this activity. To do so, we use 12 leads. A lead is simply an instrument that is used to detect a potential difference, and it can be bipolar or unipolar. A bipolar lead will measure the voltage difference between two electrodes placed on different parts of the body, and the unipolar lead will measure the electrical activity in that specific point and then compare it with other unipolar leads in different parts of the body. These 12 leads are split into 6 limb leads and 6 chest leads. The 6 limb leads themselves are split between 3 bipolar leads and 3 unipolar leads. The 3 bipolar leads are simply referred to as lead 1, 2, and 3. And they are bipolar because they measure the voltage difference between electrodes placed at our limbs. Now, let's just disregard the right leg, because we place an electrode on the right leg, which simply works as a ground electrode. On the other limbs, we place negative or positive electrodes in a way that we form a triangle called the Einthoven triangle, which works as follows. We have lead 1 that goes from right arm, where we have a negative electrode, to left arm, where we have a positive electrode. Lead 2 that goes from right arm with a negative electrode to left leg with a positive electrode, and lead 3, which goes from left arm, where we have a negative electrode, to left leg, where we have a positive electrode. So if you imagine the two arms connected, and then each of the arms connected to the left leg, there you have the 3 leads which form the Einthoven's triangle. Now, what you should know is that the electrical activity that is recorded by lead 2, the one that goes from right arm to left leg, is actually the sum of the activities recorded by lead 1 and lead 3. Besides the 6 limb leads that we just discussed, we also have 6 chest leads, which are placed on the chest and take names from V1 through V6, and they're also unipolar leads. Now, we should mention that each individual lead will basically take a snapshot of the heart from that specific lead's point of view. So we could take each lead and draw an EKG from that lead. However, the EKG that you're probably most familiar with, that you would normally find if you did a quick Google search and looked for an image of an EKG, is the EKG coming from lead 2, which, as we just said, is the sum of both lead 1 and lead 3.
So, as we said, with an EKG, we can detect the movement of charges coming from the heart. In particular, we record any electrical event, so a depolarization or a repolarization event, and we take into account the direction that the charges are moving in. Remember, of course, that by depolarization of a cardiomyocyte, we mean that the cell's membrane is becoming more positive inside and negative outside. And by repolarization, we mean the opposite. So a cell that is repolarizing is becoming more negative inside and more positive outside. Let's imagine a depolarization event. If a depolarization starting from one cell spreads to adjacent cells, we can observe a movement of charges along those cells, because these cells will become more positive inside and more negative outside, and if the depolarization wave moves cell to cell, the charges are moving both inside cells and outside cells. However, when we, from now on, we'll talk about movement of charges, we only refer to the movement of charges outside of the cells, not inside of the cells, because with electrodes on the skin, we are only detecting charges that are coming from cells and moving through tissues, so we can only detect charges outside of the cells. And how do we represent the movement of charges in order to draw an EKG? We use electrical vectors. An electrical vector is a vector which is always drawn in the sense of where the positive charges are outside of cells. This means that it will always be drawn in the same sense of a depolarization wave, but in the opposite sense of a repolarization wave. Let's see why. a depolarization wave leaves behind cells that have been already depolarized, which thus present negative charges outside them and positive charges inside them. But remember, we don't care about the charges inside cells. So just consider that the depolarized cells left behind by a depolarization wave now have negative charges outside their membranes. The depolarization wave is also moving towards cells that have yet to be depolarized, and thus still have positive charges outside their membrane. In this case, we will draw the electrical vector towards the cells that still have to be depolarized, so in the same sense that the depolarization wave is actually moving. A repolarization wave will do exactly the opposite. It will leave behind repolarized cells that have positive charges outside the membrane, because they are becoming more negative inside and leaving positive charges outside. At the same time, the repolarization wave is moving towards cells that are still depolarized and thus have negative charges outside their membrane. In this case, we will draw the electrical vector towards the cells that have already been repolarized, because they are presenting positive charges outside their membrane. So, in the opposite sense of the movement of the repolarization wave, which is instead leaving behind those cells and moving towards the depolarized cells. Let's make some practical examples. Let's say the SA node fires. Remember the SA node in the right atrium, and the atria depolarize. In this case, we draw the vector in the same sense of the depolarization wave, so from the base of the heart towards the apex, more or less. Now, let's imagine the situation where the electrical impulse reaches the apex of the heart and starts traveling along those branches of the Purkinje fibers that run back up towards the base of the heart along the ventricular walls. In this case, the depolarization wave is moving from the apex towards the base of the heart, and we'll draw the vector in exactly that sense, so towards the base of the heart. However, this is not the end of the story, because in order to understand how the electrical vectors determine the actual shape of the graph of the EKG, we have to take into account, besides the vector, the lead we are using to read this vector. In particular, the electrodes of the lead we are considering. If the electrical vector we are considering is pointing towards the positive electrode of a lead, this will result in a positive deflection in the graph of the EKG. If it points towards the negative electrode of the lead, we'll have a negative deflection in the EKG. So we now are one step closer to understanding how we get the graph of the EKG. We're still missing one step. Let's take, for example, lead 2, that goes, remember, from right arm to left leg. So it traces an imaginary line. And let's take an electrical vector that we just detected thanks to our measurements. This electrical vector will, in reality, never be exactly aligned with the imaginary line traced by the lead. So what we do is we take the vector and use its projection on the line traced by the lead. Let's take the imaginary line of the lead. Let's take the midpoint of this imaginary line. Starting from the midpoint of this line, we can draw out our electrical vector, and we'll see that this vector will not overlap the lead. For example, in the case of the depolarization of the atria, the vector will move towards the apex of the heart, but it will not precisely correspond to the line traced by lead 2. What we do is we trace the projection, so we draw a line perpendicular to the lead, starting from the end, from the point of the electrical vector, and we assign to the projection a value in millivolts. This value in millivolts will be plotted on the EKG graph, and it corresponds as a point. The joining of all of the points resulting from many vectors measured at many different times will give us a full graph of an EKG. So if you take any point on the EKG graph, that point corresponds to a value in millivolts that was given by the projection of an electrical vector at a point in time on that specific lead. How do we determine if the values in millivolts is positive or negative? We just have to see if the projections are going towards the positive or the negative electrode. If they're going towards the positive electrode, we would have a positive value in millivolts. If they're going towards the negative electrode, we're going to have a negative value in millivolts. Remember then the joining of the points of the millivolts will give you a full curve on the EKG. Let's make some practical examples. If we go back to the previous example, the depolarization of the atria would yield an electrical vector that points towards the bottom left and thus towards the positive electrode of lead 2. And in fact, the projection of such vector on this lead will have a positive value in millivolts. On the contrary, the depolarization of the epicardial portion of the ventricles, thanks to the Purkinje fibers, would yield an electrical vector that points to the top left, so towards the base of the heart, and towards the negative electrode of lead 2. In fact, the projection of such vector on lead 2 will have a negative value in millivolts. I know these general concepts might be a bit abstract and confusing, but now we'll look at an actual cardiac cycle on an EKG, and we'll explain to you why the curves are positive and negative and the movement of the charges.
Alright, so remember that the EKG is a representation of the electrical activity of the heart throughout the entire cardiac cycle, which lasts approximately 800 milliseconds and goes from a moment where the entire heart is repolarized and the atria start to depolarize until the moment where, again, the entire heart will be repolarized and ready to start the cycle again. In an EKG, we can appreciate waves and isoelectric segments. Waves are visible as positive or negative deflections, and they signal a movement of charges, while isoelectric segments are simply straight lines, straight horizontal lines, that signal that there is no movement of charges. The three main waves are the P wave, the QRS complex, and the T wave. The segments are the PQ segment, the ST segment, and the TP segment. And now we will look at them specifically in detail. So we start from the P wave. The P wave signals atrial depolarization. It shows as a positive deflection on the EKG because the sum of all the electrical vectors that are detected during the wave of depolarization of the atria will point downwards and to the left. Therefore, from the atria in the direction of the ventricles, which is also the direction of the positive electrode on the left leg. Remember, we're looking at lead 2. Because the electrical vectors point towards the positive electrode, the deflection will also be positive. After this deflection, we have our first segment, which is the PQ segment, which signals the period where the atria are fully depolarized and the ventricles are fully repolarized. This corresponds to the moment where blood is being pushed into the ventricles and ventricles are filling. Then we have the QRS complex, which is actually a triphasic wave. Why triphasic? Because it is made up of three individual waves, the Q, the R, and the S wave. The Q and the S waves are small and negative, while the R wave is big and positive. So the Q wave, in particular, signals the depolarization of the septum. You might be wondering, if the septum is depolarizing from top to bottom, why is the wave negative? Well, the fact is that although the depolarization wave is indeed going through the bundle of His and reaching the Purkinje fibers from top to bottom, the septum is a very thick piece of tissue that has to be depolarized from inside to outside. So the bundle of His will cross the septum around its middle axis, but then the depolarization wave is going to spread from the medialmost to the lateralmost portions of the ventricle, and in a slight upward sense. Because it's in a slight upward sense, the sum of the electrical vectors will actually end up pointing upwards towards the base of the heart, thus towards the negative electrode in the right arm. The R wave, instead, will be a very tall, strong, positive deflection, which signals the depolarization of the ventricles, which instead will actually go in the direction from top to bottom. Finally, the S wave is also small and negative because this corresponds to the depolarization of the epicardial region of the ventricles, which is carried out by the Purkinje fibers. And remember that the Purkinje fibers curve at the apex of the heart and go back up towards the base. Thus, again, the sum of all the electrical vectors will actually point towards the negative electrode. You should also know that during the QRS complex, which we said is only the depolarization of the septum and the ventricles, there is also the repolarization of the atria. However, there is so much more electrical activity going on in the inferior chambers that the repolarization of the atria is almost negligible and doesn't show on the EKG. After the QRS complex, we can appreciate the ST segment, which is a period of time when the atria are fully repolarized and the ventricles are fully depolarized. And this lasts for about 260 milliseconds, and it corresponds to the plateau phase that Francesco explained to us previously. Now that the ventricle has depolarized, it also has to repolarize. This is signaled by the T wave, which turns out to also be a positive deflection and might be a bit counterintuitive, because if the depolarization of the ventricles was positive, and we previously said that the electrical vectors in the case of a repolarization event are opposite to a depolarization event, shouldn't the T wave be negative? Well, no, for the simple reason that the repolarization wave does not actually go in the same direction of the depolarization wave, therefore from top to bottom, but it goes from bottom up. This is because the ventricles repolarize starting from the cells that had depolarized last, because these cells have a shorter action potential. So as soon as they are depolarized, they will start repolarizing and start a wave that instead of going from top down, it will go from bottom up. Because they go from bottom up, and this is a repolarization wave, the vector will point down towards the apex, so towards the positive electrode, and the deflection will be positive. After the T wave, we can appreciate on the EKG the TP segment, which signals the moment where both the atria and the ventricles are fully repolarized, and we wait for the beginning of a new cycle. Alright, now that you guys know how we detect electrical activity of the heart and how this looks like on a normal EKG, let's consider abnormal EKGs and the pathologies associated with them.
So we can divide abnormal heart rhythms in three main categories: abnormalities in rate, abnormalities in rhythm, and cardiac myopathies. Abnormalities in rate consist of abnormal spacing between cardiac cycles, so either an increase or a decrease in time between two cardiac cycles. The two main pathological conditions are tachycardia and bradycardia. Tachycardia refers to a heart rate faster than 100 beats per minute, while bradycardia refers to a heart rate slower than 60 beats per minute. Abnormalities in rhythm consist of abnormalities in the regularity or the spacing between waves. The main pathologies of this kind are atrial flutter, which consists of extremely fast atrial depolarizations, even 200-360 BPMs, and the ventricles cannot keep up with these fast atrial depolarizations due to their refractory period. Then we have atrial fibrillation, which consists of rapid, irregular depolarizations and contraction of the atria. In this case, ventricular rhythm also becomes irregular, and we can see sporadic QRS waves. Then we have ventricular fibrillation. In this case, impulses in the ventricles are traveling randomly in every direction, and there are no discernible waves that we can see in the EKG, and the heart becomes completely inefficient as a pump. Then we have ventricular tachycardia, which are fast but usually regular abnormal contractions of the ventricles that start usually from an ectopic focus in the ventricles. Finally, we have heart block, which results from a blockage in conduction between atria and ventricles and can have varying degrees of severity depending on the level of the blockage. Complete heart block, the most severe, results in normal atrial rhythm but slower ventricular rhythm. In this case, the P waves will be normal, but the QRS and T waves will be slower and completely independent from the P waves. The third and last category, as we mentioned, are cardiac myopathies, which consist of tissue damage of cardiomyocytes. There are only two pathologies of this kind. The first one is myocardial ischemia, which consists of inadequate delivery of oxygenated blood to the heart tissue. In this case, we can see abnormal QRS waves. And the other, more severe condition is myocardial infarction, which is actual necrosis of the heart tissue. Also, in this case, we can see abnormal QRS waves. Last but not least, we actually have some paraphysiological disorders, the main of which is extrasystole. Extrasystole can be atrial or ventricular and is usually harmless. The cause of this disorder is unclear, but we know it is prompted by stress, alcohol, and caffeine. It results from an ectopic focus that starts a depolarization event before the SA node can fire, which produces an anticipated beat. After this anticipated beat, there is a compensatory longer than normal pause that happens before the next normal P wave can occur, resulting in the feeling of a skipped beat.
Alright guys, this was everything we think you should know about the electrical activity of the heart. If you like this episode and you would like to learn more about cardiovascular physiology, make sure to follow us on YouTube, Instagram, Spotify, and we will see you in the next episode. Goodbye.